without further ado, what I'll do is ask, starting with Chris, if you don't mind, just give us a little bit of background on yourself.
Thanks. Chris Mullins with UnitedHealthcare. I'm the Executive Director of the health plan here in the Mid-Atlantic region that covers Maryland, Virginia, Washington, D.C., and West Virginia. I act as our market lead in the state of Virginia and report to our CEO. I've been with United for 6 years. Most of my experience has been in the running our sales organization for the large employer segment of UnitedHealthcare, but I also have background in underwriting in the healthcare field. In my new role, I have gotten involved to a certain degree in the regulatory areas, as well as building and furthering relationships with providers in the healthcare system.
Thank you. Mike?
Hello, I'm Mike Ford. I'm with MedAlliance Management Group, and we're based out of East Tennessee. We're a small regional provider of management consulting services as well as business process outsourcing for about 6 states. And I've been in healthcare 20 plus years, and the first half of that was primarily in hospital-based activities and operational management, financial roles with hospitals, hospital alignment strategies, and merger and acquisition work. And then I had an opportunity about a decade ago to switch roles into what we call the professional sector of healthcare, working primarily with physicians and allied healthcare professionals. But all of my experience is inside the industry, in the delivery models and the delivery of healthcare. So my perspective, as it relates to you guys, is unique from that standpoint of what we try to protect and how we try to protect that, and delivering a bottom line to our clients is that end user agreement between the patient, which is what this is all about, and the providers.
Let me skip Alex. No, go ahead.
Again, Alex Adler, and it's great to see a bunch of you again that I met last night. I am a broker, which means that I am the one with the distinct privilege of coming to your office every year and telling you that you had a 23% increase on your premiums. My company is HGA Financial. I founded it about 7 months ago. I have about 10 years in the business. So I've seen the ups and the downs as far as premium increases, premium stability, and a bunch of changes in the marketplace, including the cost shifting that's going on recently. So as a broker, I work with the carriers to present the best offers to my clients. I have clients across 10 states at this point, and it's just, again, good to be here this morning.
Okay, thank you. Let me get the ball rolling, and then we'll go around the audience here and get some of their questions. But in view of the Supreme Court hearings that have been going on this week, can you just give us maybe a perspective of individually where you see the future of healthcare reform? And maybe, Chris, I'll start with you.
Sure. So obviously that's the big news this week. I guess 6 hours of oral arguments to the Supreme Court justices. Right now, UnitedHealthcare's viewpoint is we are prepared to, enact the provisions of healthcare reform as they were passed a couple of years ago. We're well down the path of implementing, the various provisions of the law, and really there's nothing else for us to do other than to assume that the law will be upheld the way it was originally passed, and that's the path that we're taking right now. The only other comment I'd make is there's been a lot of discussion around the individual mandate and whether it's constitutional. And I know one viewpoint that the company has is that one thing we would not want to see is the elimination of the individual mandate, and some of the other tenets of law stay in place, like the elimination of pre-existing condition limitations. I think that would be problematic for the industry as a whole. I think it would cause costs to increase across the industry to not allow participation in the pool by everyone. So other than that, we're standing and waiting like everyone else to see what happens, but we're staying on the path of implementing the law just as it was passed.
Mike?
From our perspective on the delivery models and the delivery providers of healthcare, we've been scrutinized with the regulatory environment for a long time, well over a decade. So we're a bit more reactionary to this law has certainly put an onus on a more heightened awareness of what's in it. But essentially what we're looking at, again, is ever-increasing demand with the population, and certainly the bolus of lives that we call baby boomers that are living longer and will demand more out of the system, and unfortunately never decreasing input of revenue. So, from our standpoint, from a macro standpoint, you'll see huge shifts in healthcare delivery. There's projection of additional closing of 30%, up to 30% of hospitals in the next decade. I think the focus will shift. It's been about a 12-year focus on the independent side of healthcare, physicians in particular, the last decade, and the shift obviously will now focus on the hospital side and the integration models from their perspective. There's a huge amount of force right now in the hospital sector to vertically align, and Sue's going to withstand this onslaught of this kind of these macroeconomic pressures.
Thank you, Alex.
Yeah, it's been very interesting listening to the little tidbits from the hearings this week. The little bit that I've caught, and 6 hours of hearings is completely unprecedented. They've covered 4 separate areas of the bill, but the biggest one that's potentially going to have the biggest effect on everybody is that individual mandate. The bill really, there were 3 areas of healthcare that needed to be addressed. There was the quality of healthcare, there's the affordability of healthcare, and there's accessibility to healthcare. The one that I think was addressed the most was the accessibility. There was a huge push to get the uninsured covered, and that was done fairly successfully. The one area that I think was lacking, and take this as opinion if you will, but the one area that was lacking was the affordability. And I don't think that there were enough measures put in place to really keep premiums in check. There were a lot of mandates, a lot of preventive care, for example, that was mandated in the bill that can only drive costs up. So without checks on the other side, it's a dangerous situation. And as Chris alluded to, if the individual mandate is thrown out, that's a huge funding mechanism for the rest of the bill. So it's going to be very interesting to see come late June. Right now it's all speculation, but come late June, it's going to be very interesting to see if that severability clause comes into play, if they throw the whole bill out, if only the individual mandate is struck down, and based on all these different situations, how that's going to play out.
Very good, thank you. Questions? No question. Come on. Very good. Let me come in. Thank you.
Alex, I wonder if you could just follow up what you just said with a little bit more detail. If the individual mandate is struck down, what impacts do you see on the remainder of the bill?
It's a great question, and I'll go back to cost because the individual mandate, again, one of the biggest reasons that was put into place is to provide funding. Essentially, when you're talking about insurance, you're talking about a risk pool, and in order for that to work effectively, you have the sick and you have the healthy, and you have to have the costs offset one another to make it successful. So the individual mandate was put into place to force the younger, the invincibles, the 20s and 30s that think that they're going to be healthy forever, to purchase coverage to offset the cost for the ones that are using most of the benefits. The trends in utilization are quite scary, actually. A lot of preventable conditions, obesity, heart disease, diabetes, to name a few, are off the charts. So unless there's funding on the other side, people that are paying into the pool without utilizing a lot of the benefits, all that's going to happen is that there's going to be higher utilization, therefore higher costs, and quite frankly, I'm not sure that there's really an end to that.
Mike or Chris, do you want to add to that? Or?
Yeah, no, I just reiterate what Alex said. I mean, that's the big issue. You need to have that balance in the pool. Health insurance works the same way a lot of insurance works. If only those who need it are in the pool, then the strain of that is going to affect anyone who remains in that pool. So if you're an employer or a business who has insurance and the pool deteriorates, there's going to be an adverse effect on all. And I think that's the big concern.
The unspoken assumption in here is that covering more people will not change the rate at which people use the healthcare system, in this, as you put it, the invincibles, the 20 and 30-year-olds. Well, there's plenty of evidence in other insurance environments and in other countries that once you create a sense of entitlement in people's minds, that the system is going to go to the rails because of vastly increased use. I mean, right now, you're 25 years old, you get a cold, you suck it up, you don't bother. But as soon as you have a right to health care, everybody is going to be in there, and it's going to make the current levels of hypochondria seem trivial. And I don't think anybody who thought through this 2,700-page bill gave any thought to the practical economics associated with how people react when risk is transferred away from them, whereas privileges are transferred to them. You know, the whole point of insurance is you pay a premium to offset risk. But in this particular case, what you're doing is you're removing the risk. You're not offsetting it. And I think this is a very, very dangerous approach. We're close to bankruptcy as a country now. This is just going to push us over the edge twice as fast.
Thank you. I'm not sure what the question was, but
yeah, I'd like to speak to that just briefly. Number one, the uninsured population, as much as 90% of that, if it is insured, will be on the backs of Medicaid. So as a provider, you're looking at Medicaid being, you know, if we're spending $1, we're losing probably between 20 and 25 cents on that dollar by providing services at Medicaid rates. It's just what it is. So again, when you put that bolus of lives in at Medicaid rates, you can just tell where that's going to end up with. Again, people will not be able to manage the bottom line. What we've seen in utilization trends in healthcare, the biggest impact we've seen in the last 5 to 7 years have been what we call, you guys call consumer-driven healthcare, high deductible HDHP plans, and we've seen a huge impact on casual use, what we call casual use in the healthcare system. I agree with you 100% that and part of what we've done is entitled ourselves in this in our whole system and the way it's modeled. Co-pay models and the like was kind of the nidus of that entitlement program, and so we've seen a huge impact, and not just in episodic care in the office, but in same-day surgery. If you got a bum knee, well, I'm just going to live with it. If I got my hips hurting, well, I'm not going to be able to pop out $5,000 for that, hip replacement. So that we've seen a lot of that throughout the industry, which is, again, whether you like it or not, I think it's probably the part of what we'll have to deal with in the future.
Chris or Alex, do you want to add to that?
No, I'll just say I think you make a fair point. It's certainly part of the concern. There's no easy answers to this issue, obviously, and I just think that my only original comment was if that individual mandate is struck and isn't counteracted in some other way, it's going to have some significant impacts.
Yeah, and if I may comment on that as well, excellent points, and I agree completely with what Mike and Chris just said as well. And to touch on that, I think you really need to look at the history of healthcare in this country, and that's coupled with a couple of other factors. You can see in hindsight that there was this issue being created over the years, and it was really post-World War II that there was a drive for employer-based healthcare, and employees started getting into a system where they had first dollar coverage. There was the advent of the HMOs, especially going into the 80s. HMOs became very big, where all you had to do was take a card to your provider, say, there you go, how much is healthcare? Oh, it's $10, that's great. Because it was a copay system, it was first dollar coverage. To Mike's point though, I think one of the solutions to that is to put the onus back on the consumer. Make the consumer aware of what the cost of care is. That way they know if they need a procedure, it's going to cost $5,000 at hospital A, maybe $3,500 at hospital B. Check out the quality, really shop for it like you would other things. And I think until the onus is really placed back on the consumer in terms of the consumer-driven healthcare, in terms of high deductible plans, then you're going to continue to see the trends going in the directions that they are.
One of the biggest issues that we're facing, and really we were facing it before healthcare reform, was the limited number of primary care physicians that are in this country. And there's no greater example of that than right here in Washington, D.C., where right now, there's a sore need for primary care physicians, and with healthcare reform and with the broadening of the accessibility to healthcare, which is needed, there needs to be a plan so that we have, a number of providers that are able to care for and accept these patients. And Mike, I don't know if with your background, I'm sure you have more to comment on that, but it is a very legitimate concern.
Like I said, opened up with, I think irregardless of healthcare reform, I think we've been dealing with this for a longer period of time. It's just been in the news during this current seated president primarily. But anyway, the fact of the matter is there's an acute shortage. Number one, 25 years ago at a subspecialty level, especially from the supply perspective, residency programs in most every specialty started closing. They closed, and some closed up to almost 50% of their residency programs. And that was a very, very predefined goal to limit supply, to protect their membership. And so now we have this acute shortage of primary care to supply this system again. And that will catch up on itself in the next 20 years. But again, I think we'll probably, irregardless of reform, we'll end up somewhere in between. Again, the supply versus demand is it's so counterbalanced right now. We see it that at some point in time, it's the rationing of care will either be forced upon us via regulatory environment or just the economic environment.
But when I go to do some of the elective things and try to price that out, I find that the bigger systems can't give me a price. They can't figure it out. Some of them are trying to. I've been directed to websites or to certain things that don't really give me anything. How can these big hospital systems or doctor systems get pricing that really is accurate, or can it get it out there to the consumers? Because it's really not out there right now.
Chris, you probably can comment on value-based contracting. It's very fragmented, I agree, and again, we representing physician practices primarily in multi-specialty to single specialty practices. Again, I think I've seen just in the last 2 years or so, you'll see, some sites to view health grades. If you're looking for performance factors, quality factors, but again, pricing models. Again, direct pricing models, and Chris can comment to this. Either based on their contract, or if you're looking as a consumer to go out and let's say you want to have a knee replacement, there's really not an avenue right now to be able to go out and shop that and put those 2 or 3 prices out there and select the one you want.
Well, I can comment from UnitedHealthcare's perspective. We do have tools that we make available to all our members. It's called a treatment cost estimator, and you can go online, and if you are having a knee replacement surgery, you can go in there, you can tell the tool where you're located. It will give you results based on your location and the contracts that we have with providers in that location. It will give you the total estimated cost for the total episode of care, so it won't be just the knee replacement, but it will be any preoperative, postoperative visits, medications that go with that. And it also ties in your individual plan. So if you have a deductible and coinsurance, it will give you not an average plan, but your individual plan, and let you know what the cost is if you go to a UnitedHealthcare network provider or a non-network provider. So I think it's about as good as it gets in the industry, and I'm not up here trying to sell one of our tools, but I think most of our competitors have tools of some variation. From the hospital or physician's perspective, for them to be transparent, I think it's complex. They manage contracts with a lot of different payers, including the government, Medicare and Medicaid. They don't necessarily know what your plan benefits are, what's covered, what's not, what's subject to the deductible or coinsurance or things like that. But I think we've come a long way in terms of our industry in being able to tell consumers and give them an idea of what the projected cost of a treatment plan is than we were even a couple years ago.
Yeah, your question actually brought to mind the case that I dealt with just recently, a couple of weeks ago. One of my clients needed a procedure done, actually, to repair a deviated septum. And he called me because he had called the provider, which was not UnitedHealthcare, for the record. UnitedHealthcare does a good job on that. But it was with another carrier, and he had called the carrier several times. He had called his physician's office several times just to find out how much he would be responsible for, because there wasn't just the physician's fees, there were the hospital fees, there were a whole different set of fees there. He had gotten 3 different responses after 3 different phone calls as to what he would be responsible for. And one of the responses is that he would be responsible for 10% coinsurance, which was nowhere on his summary of benefits. There was nothing saying 10% coinsurance. So the reason I bring that up is I agree there needs to be a better streamlined functionality in letting consumers know what those costs are going to be. If the onus is going to go back to the consumer side, then there need to be better systems in place. And in all fairness, United does do a good job of giving you an estimate. But there has to be a place where you can go and enter your plan, enter what you need to have done, enter the physician's information, and just find out what it's going to cost and really do your shopping. If you want to go find a big screen TV today, you don't need to go far. You go to the internet, you find Best Buy, you find this shop, you find that shop, and you see the prices right there. It's very simple. And that's very far-fetched from what it looks like in the insurance world right now.
I'll add a comment. We've seen sort of a separation in just in the last 12 to 24 months with self-insured. I'm a small employer, so I have fully insured product for my employees. But if you work for a large enough employer where it's self-insured and you have a third-party administrator using a network or a negotiating backbone, we have seen employers directly negotiating with hospital systems as it relates to services for obstetrics, cardiovascular services, primarily open heart and catheterization services, some GI services, and competing hospitals are actually, again, laying on the line, this is what we'll live to for that episodic service. And I think that's probably, we don't really have that streamlined avenue right now in the fully insured world, but again, you're sort of you're at the mercy of whatever contracted rates that United has developed, or Aetna or Cigna has developed in that market with that group of providers. But I certainly think it's coming.
One thing I'd say too is I think all or most of you are business owners. Whatever health care insurance provider that you have, they have given your employees and their covered family members a lot of tools to make better decisions in health care. And I think it's critical and vital that you encourage those employees to use those tools. As Alex said, the average individual spends 10 times the amount of time investigating what kind of TV or car or something like that to buy than they do when it comes to a major healthcare decision. And I think people are genuinely uncomfortable shopping for a healthcare procedure the way they would for a TV. They rely on their doctor, their advice of their doctor, but it is their health, and I do think there needs to be a little bit of a shift in attitude in how much time that we look into what the best quality option is for whatever my healthcare need is. And as employers, I think that you should spend time with your employees in making them aware of all of the avenues they have to help make those good decisions, and invest the time to do that.
Chris, just to comment on your statement, we just recently switched to more of a consumer-driven plan, an HSA, and it's significantly changing how our employees purchase services. So they're now becoming more engaged in that and wanting to know what it's going to cost. So I think you're right about that. My question relates to the Affordable Care Act and what you would do if you were a healthy young person and you were choosing between buying insurance for $5,000 or $6,000 a year and paying a fine of $2,000 for not buying, since there's a requirement that you as an insurance company have to accept people with pre-existing conditions, would you just wait until you got sick and then buy insurance, or would you pay the extra costs now?
I'd buy the insurance.
Why?
Because I'm not young and invincible. No, but I mean, you raise a good point. I mean, that's obviously an issue. I mean, the penalty for non-compliance doesn't equate to the cost of purchasing insurance, and I think a lot of people have been pretty vocal that you know that's an issue, and it's one to be concerned with. And I think, you know, to your point, there's going to be a lot of people who will sit there and do this and come to a pretty quick decision that, you know, hey, it's cheaper for me to pay the penalty and roll the dice. I'm 25 years old, and you know, I'll deal with it when I have to. So, you know, it's a legitimate concern, an issue.
Yeah, and I don't think with that quote-unquote young invincible crowd, I don't think the second half of that equation even comes into play most of the time, which is the consequences. I think they see it as a financial proposition, and if you can't afford the coverage, or if you don't want to afford the coverage and you don't find a value in the coverage, then you're not really worried about what happens later. I don't think the thought process is either I buy this now or maybe I'll get sick later and I'll need this. I don't think the second half of that equation really comes into play most of the time. So yeah, to Chris's point, the penalties aren't stiff enough. And the penalties are going to be in the form of taxes. How many of them pay their taxes on time, if they do? So, you know, the collection of the penalties and fines, I'm not sure is going to be the best method of making up for that cost either. So there's just not as much of an incentive to get them in that risk pool.
Let me ask you a quick question here, and one we discussed earlier. Are corporate wellness programs working, and what kind of return on investment are you seeing because of the influence on employees' lives and health? Chris?
They absolutely work. I don't know why anyone wouldn't do it. It's like preventive medicine. It's a good idea. I know there's always the pressure to, you know, demand or understand what the ROI is. I think only good can come out of corporate wellness programs if they're administered properly. In general, we see the return on investment being about 2.5 or 3 to 1. So for every dollar you invest, you know, you're getting more than $2.5, $3 back. You know, most companies are doing wellness programs. Our experience has been that the most successful wellness programs are ones where there's leadership at the top of the organization that's endorsing them, that it's your program as an employer and not the insurance company's program. It's your program that the insurance company is administering for you. You know, maybe helping you design and develop so it meets your needs. But if you have buy-in and endorsement from the leadership in the organization, then employees and family members are more inclined to participate and engage in the program. So they're absolutely a good idea. There is a return. And you know, I think it's one of the good things that's going on in our industry right now, the engagement. And I think the most difficult part for you as an employer is how do you engage your members into these programs. But it starts with leadership at the top in that endorsement. You know, it starts with getting wellness committees set up inside your organization to help drive that engagement. Again, I think that works a lot better rather than relying on the insurer or you know, vendor, if you will, to drive that engagement. You all have your own cultures. You know what drives engagement within your organizations, and I think that's what gets the necessary and needed participation.
Anybody else?
Yeah, just excellently answered. Just to elaborate a little bit on the returns, and a lot of it is difficult to quantify, but there have been different studies that have shown that things like online wellness evaluations have anywhere from a 4-to-1 to 6-to-1 return.
I'd like to go back to Steve's comment about HSAs and even address a little bit of what Harry was saying earlier, this issue of entitlement. And, you know, HSA programs have been around for a while, but I'm amazed how many employers are not even told about them. These are programs that are excellent programs that allow people to make good decisions about their health care. I mean, we've been on an HSA now for at least the past 3 or 4 years. Our company is self-funded as an insurer, and we also have a wellness program, and we offer 3 different forms of premiums, one of them being the HSA. And it seems like there's just a lack of education that this is even out there, because it gives you a lot of options. It's kind of the best of both sides, because you can put money away and have it there if you need it for something, and if you don't need it, it carries over year after year, and you can even take it into your retirement. So why isn't there more said about HSAs, especially from your community, when it seems to be a good solution for both sides of the problem?
It's a great question. From my perspective, as a broker, when I'm proposing different plans to clients, the HSA is always going to be on the table. But quite frankly, a big reason for that has been the increases in premiums. So the HSA plans are priced more affordably for companies. So it's been almost a forced shift into the HSA market. I think a lot of the drawback to an HSA, and you brought up a great point, which is the education piece, but a lot of the drawback to an HSA is the concept of providing the employee with a plan that no longer has that $10 or $20 copay, but instead has a $1,200 or $2,000 deductible. And if you're a family, well, hey, $3,000, $4,000 deductible. For the employee to be faced with that kind of decision is difficult. Even though it's going to force them to make the right decisions and potentially be more cost effective for them, the only thing they see is that huge dollar amount that they're going to have to pay out of pocket. The question of funding comes in as well. Who's going to fund that deductible? Is it going to be funded by the company, by the employee? Is there going to be a split? And a lot of the carriers do a good job of mandating that no more than 50% can be funded by the employer. But there are still carriers out there that allow first dollar coverage, that allow the employer to fund the full deductible. So, you know, a lot of times it's being used for just cost reduction. So you're basically just working your way down the ladder of what's going to be the cheapest plan out there. Back to your point, though, about the education piece. That is, in my opinion, the single biggest component of an HSA plan. If the employees or if the company doesn't understand how it works and how to really utilize it properly, then it's just a nightmare waiting to happen. And all you have is a high deductible plan that nobody's going to like. But if the education piece is there and people can get on board, sure, they're extremely effective. Extremely effective.
You know, one comment I made, how many people in the room are from the DC metro area? Anyone? You know, this area has been notorious in its slow adoption of HSAs. Primary reason being, I think from, if you're an employer from a competitive standpoint, we live in a town where there's a lot of government employees in healthcare. They have very rich benefits. There's a lot of government contractors who have very rich benefits. And a lot of employers have, even though I believe we've been talking about the virtues of HSAs a lot, from a lot of employers locally feel from a competitive standpoint, their benefit packages won't be as competitive as what's available out there in the market. So I think that's one reason for the slow adoption here. the adoption rates have varied around the country. In the Midwest and the South and Southeast, they've been a lot higher than they have in like the Northeast corridor, which has been dominated by HMOs and first dollar coverage and the influence of, like I said, government type benefits. So, but I do think that we do spend a lot of time talking with people like Alex and his clients and employers about HSAs. What I have seen locally is a trend of offering at least an HSA as an option. The uptick in enrollment in there is relatively slow, and most of my perspective is in the larger employment, employers with at least 100 employees. Overall, I think we've got about 4 million people across the country enrolled in HSA type plans, and we've got a lot of good data on them, and they do have the desired effect.
I work in the Nashville metropolitan area. The laboratory that I work for has went full HSA over the past several years. It's been a stepped process. And one of the trends that I'm seeing in the Nashville area are companies that are having tiered premium programs for lifestyle. And so if you're a smoker, if you're overweight, so on and so forth, your premium may be higher. Is this a trend that's going to continue? And the reason why I ask is we have just instituted a wellness program that you were speaking of earlier, and in order for that wellness program to benefit us, we have to have a certain amount of participation, which we did get. I can't remember what percentage it was, but it was a pretty high percentage. And we've not seen the benefits from it yet. But I guess where I'm going with this is the premium situation. Is that trend going to continue where there will be differences in premiums based on your lifestyle?
Yeah, I think it's a fairly new trend. And I've seen that a lot more in the way of incentives, not necessarily penalties if you're a smoker, but more incentives. By completing a wellness program, by completing an online assessment, you have the possibly X amount taken off of a deductible, or X amount in terms of a gift card sent back to you, whatever it might be. So there are more incentives out there, especially through the wellness programs. As far as tiered programs, in terms of charging smokers more or things on those lines, I think that's difficult. It is a fairly new trend, and I do expect that it would continue to an extent. There are state mandates, depending on where you are, that would prohibit that. There are mandates based on the size of your company that would prohibit that. So, really when you're talking about a specific market, it's difficult to answer if that trend is going to continue in your market, because again, there are mandates based on that market and the size of your company.
Well, I'm just curious because, it's not just smokers, it's obesity, it's a number of other things. And I guess the fear within the companies is at some point, is your life going to be so invaded that, that your insurance is based on everything you do wrong rather than the things that you do right?
And certainly I'm not an employment attorney, but that's a huge concern. If that was me, that's a huge concern. One of the big stories recently was employers asking for Facebook login information. So, you're infringing on very personal information there. The obesity, for some people, is a choice. For some people, it's not. There are hereditary issues. You don't want these things out there as an employer, in my opinion. My unprofessional opinion at that. But
yeah, this is a little bit of it's a good topic and a great question. It is a trend that I think we'll continue to see. Anybody who's considering putting in an incentive program around health status or lifestyle, I definitely would follow Alex's lead and encourage you to talk to your in-house counsel or attorney about what is legal to do and what's not. There's a lot of incentive programs out there. The bottom line is 50% of the healthcare costs in this country are modifiable. It's things that we have control over. It's choices we make every day. And 50% of healthcare costs is due to things like hereditary and environment and things like that. But all of us and all of, for those of you business owners who have your own plans that cover employees, we're all making a lot of choices out there that impact the healthcare cost and the cost of your program. And there's a lot of good programs out there, again, to engage your employees in so that they make the right choices and to incent them to make the right choices. You know, a lot of these programs are simply to start along a path of educating yourself. So, you know, if you can put in a program for, you know, a diabetic to enroll in an educational program, and, you know, the incentive is to maybe eliminate their deductible, I think that's a great thing because it encourages the type of behavior that you're looking for to make a good impact.
A couple of thoughts and maybe a provocative question for you. I think it's Mike in the middle, right? I was listening to your description of hospitals bidding back and forth, and just what immediately came to my mind was, boy, if I'm having that open heart surgery, do I really want that guy who's about to stick the scalpel next to my heart? Is my last thought going to be, boy, that's the low bid guy right there? And so that concern. Alex, I was very interested with a comment that you made on the history going back, where it sounded to me, and I actually agree with it if it's what you were alluding to, was that employers providing health care is part of the problem. And, you know, I've often thought, boy, you know, maybe we ought to eliminate employers providing health care, give the employees some bucks and say, here, it's on you. I don't know if you've ever taken it to that radical extreme, but that, to me, I think that's where you were headed with that. And so here's my question. Harry, I'm going to pick on you just a little bit because I know where you are as far as your thoughts on Obamacare and stuff like that. But can you guys go back in time to pre-Obama days? And for Harry, the sun's coming out and the birds are chirping. But go back to pre-Obama days, and can you comment as to whether you think the system was broken?
Yeah, I'm happy to take that first. Yeah, the system absolutely was broken. It was broken in a lot of ways, and it's tough to really address where, the first place where it was broken. But to your point with the employer-based coverage, I think that was certainly one of the areas. And I'm not sure that I'm getting at eliminating employer-based coverage, but certainly it's a place where we can point our fingers to say that's one of the areas where this train started going off the tracks a little bit, because it was a competitive environment. Employers wanted the best employees. Employers wanted a workforce, period. So in order to attract and retain employees, they had to provide perks, and healthcare became one of those perks. Then it became a fight to get the best employees out there and to have a better plan than the company next door. So you went from the types of coverage that the consumer has to be more aware of to the first dollar type coverage, to more of the premiums being paid by employers. So that's certainly one area where the system started going wrong. But there are so many issues out there that were broken. Everything from the legal aspect of it to the manner in which Americans take care of themselves, to the utilization, to the lack of, as Chris mentioned earlier, of primary care. There are a lot of areas where it was broken. So I'm not necessarily saying whether I'm for or against the PPACA and whether or not I think it's a good thing. But there needed to be fixes. And a couple of years back, before that bill went into effect, I was in a session with Senator Cardin from Maryland. And one of the points that I brought up was, instead of trying to take this whole big system and try to revamp it as a whole, why not take little things piecemeal? Why not figure out where, there are myriad areas where it's broken, so why not take them one at a time? Take the low-hanging fruit, is what I told them, and start addressing those areas first. And see if you can find a solution to the problem that way. So, perhaps trying to attack the whole bundle at once might not have been the best idea. But yeah, it certainly had to be addressed, or else the issue was just going to keep skyrocketing.
Yeah, my comment, we hear a lot about patient protection, quality-based medicine. I absolutely disagree with. I think the patient has been paramount. Again, that relationship, the end-user agreement, we call it, has been very well protected historically, and I've been in it 23 years, and always a pristine, including through the continuum of the healthcare delivery system. I certainly think it's broken from the standpoint of sustainability at this growth pattern. But again, you've got demand at an all-time high and ever increasing, and so a lot of this is at a macro level that to some degree is out of out of our control. But I think culturally there's a mismatch. Again, the way the benefits are offered, our expectations as a culture, and what the system can provide. So until those are somewhat in line, we'll continue having this debate.
Go ahead, Chris.
Yeah, I think it's absolutely broken. I don't think you can find anybody say that that's not true, or at least in need of repair. I don't think anything gets to the top of the presidential agenda without being in need of some repair. I think one thing that I feel strongly about is healthcare is a right, but it's also a responsibility. And one of the things that wasn't addressed adequately with healthcare reform is the underlying cost of healthcare. I think accessibility an issue, obviously, but it's the absolute cost of healthcare that's driving the issue. And there needs to be a lot more focus on the quality of healthcare versus the unit cost. You made a good point. There's a lot of people that feel, if they're sitting on the operating table, they don't want the last thing to go through their mind is, was this guy the low bidder? But the other part of that was, they may be the low bidder, but they may have they may be the most expensive surgeon, but they also might be the surgeon who's the highest quality and has the lowest readmission rate and has the lowest complication rate, and the overall cost of care is the lowest. And that's what we need to try and get people to understand. And I think as individuals, we all need to take more responsibility for our own health care. It's not, I had my baby for $10 or I had my knee replacement for $10. There's a cost that's below that $10 that people need to better understand. And I think we all, whether we're an individual or an employer or a business owner, we have a responsibility to get people to think that way.
Thank you. This is Bill Ford, and that actually happens to be Mike's brother, so I'll let you guys decide which one's the younger, okay?
I think the gray hair gives that away, Rick. A couple of thoughts and then a question, just in follow-up to some of the comments. We've heard about these waivers being provided by the administration, and there's a reason for that. We've got a larger client out in California, and they've got in excess of 10,000 employees, and recently they've spent about $18 million studying this potential new legislation and the impact, and their solution was, we're going to move all our employees to part-time. The legislation doesn't address that and allows us to schedule our employees as we deem fit. It's not good for every industry, but the impact for a lot of folks in the system could be negative in terms of just reducing hours of work and bringing them below the requirements. The other thing on wellness, and it's quite controversial, but we work with a firm out of Atlanta, and he does a lot of benefit consulting and with Fortune organizations. And a lot of our clients have been very frustrated with these voluntary types of wellness programs, lots of cost, And I mean, take a look at me. I'm overweight, probably drink too much and those kinds of things. Hey, look, that's the lifestyle I choose. What we're seeing is, and I think you'll see more in these wellness programs, are penalties associated. The wellness program is voluntary. If you elect not to participate in the wellness program, guess what? You're paying more. Once you go into the program, the first year we have a nurse come in, professional provider, assess that employee on 5 points. Maybe it's smoking, maybe it's weight, maybe it's whatever it might be. And they give you a year to address those things. If you don't address 3 out of those 5 areas, guess what? You're paying more. So they're pushing accountability into the system. And for wellness to truly work, that's where a lot of folks are headed. And their thought is, well, we may lose some employees. However, why should our group of employees pay higher rates because some folks want to do whatever they want to do after hours? So you might see more of that kind of aggressive wellness system. The question would be, which it doesn't seem to be addressed in the current legislation nor otherwise, is if my back's hurting and I go to my provider and all of a sudden a number of tests are ordered and the system starts grinding a little bit, how much is that due to tort concerns in terms of providers being concerned about being sued, or the provider just grinding the system?
I echo Harry's frustration, a small business owner also, about the same size. And every year I dreaded June because that was our renewal date, and I knew the guy would come with a big sheaf of papers and I'd get this whole kerfuffle and try to sort out what the best options were. At the same time, going back to my employees and say, you got to pay more, you got to pay more, and you got to accept less. Seriously. And something had to be done. And to Trevor's point, what would you do unwinding a few years ago? And I'll just share an anecdote. One of my younger staff members got a rare form of cancer. It was undiagnosed for a long time. Fortunately, it was diagnosed and treated. And in that cycle, I had chosen a reputable broker and went through the whole due diligence process and signed everybody up, and it had been going along. Well, unbeknownst to me, about halfway through this guy's treatment, his wife finally came to me in tears practically, saying that she wasn't getting reimbursed and she was carrying about $90,000 of unpaid bills and collection agencies coming back. Well, I finally had to engage my lawyer and say, go chase these guys down, because none of us were getting any satisfaction. Well, he dug into it, and this licensed broker in Maryland apparently had catastrophic coverage that was underwritten by Lloyd's of London. And it became a question of almost taking it to litigation in order to resolve these kinds of this unpaid situation. Well, they elected not to renew us, and I deselected them before they elected not to renew us. But something had to happen. This was pre the Affordable Care Act, and I was all for the reform, and I don't have any stake in the game at all, and even less understanding of the complex situation. But if you were to unwind this a couple of years, what would a reasonable restructuring of the system look like? And I know it would take, a treatise to do that, but some of these things just had to be fixed, and it's maybe more along the lines of a Harry comment than a question, but.
That happens in the cast section, doesn't it? Do you want to make any comments, guys, on that? Or
speaking just, go ahead, Chris.
No, I just say I'll leave it pretty general, but reasonable restructuring. Again, I'll just go back to focus on quality and affordability. I think is the biggest issue.
And reasonable expectations.
Mm-hmm. Yeah.
I think that really lacks in our dialogue.
Yep. But I think that's where the law fell short, and I think that's the biggest underlying cause. So quality, affordability, personal responsibility, all of that, measures in significantly to the overall cost, and that's where a lot of the focus needs to be.
Yeah, and I was just going to mention, going back and trying to come up with a better solution, this has been going on for the better part of 3 or 4 decades as far as Congress trying to find a good solution for this. There have been several attempts throughout the years between Kennedy and Hillary Rodham Clinton and now Obama's proposal. There have been several attempts at revamping the system, and most of them were shot down before they ever saw the light of day. So I think that question as a whole is way beyond the scope of, not to belittle any one of us up here, but if Congress and the whole country can't figure it out, I'm not sure a panel of the three of us can answer that in the next couple of minutes. So, sorry if you were oversold on this.
But Alex, that's why we provided you with a flip chart. Come on, let's go. Jimmy, go ahead.
Good morning. Really great discussion. I want to piggyback on the waiver situation. We were just discussing the waivers here silently in a sidebar conversation. But how many firms received waivers? Why did they receive waivers? And where do you get an application for a waiver? Well, I know there's hundreds of them, and they're really relatively large firms, and I think you know who they are. You know some of them. But what happens to the part-time employer? Then we hire a part-time employer. A lot of us hire seasonal people for summer months, 6 months interns. Who's responsible for paying for their insurance?
Yeah, self-funded plans, you're dealing, typically when you get into the self-funded market, you're dealing with larger organizations, and most of the provisions of the bill, especially come 2014 when you have to deal with the exchanges and such, are aimed at the smaller companies. So the impact to the self-funded groups isn't going to be as great. You're still going to have some mandates placed on you, but no sweeping changes in terms of, or I should say as great as in the smaller group market, which is the fewer than 100 employee marketplace. I'm not sure if that gets to your question or...
Well, IRS classifies small business as less than 500 employees.
Mm-hmm.
We fall into that category. So you're saying there's less than 100 is going to be impacted more than greater than 100?
In terms of the health insurance bill, 100 is the cutoff, especially when you're talking about the exchanges. They're defining the small group as 100 or less. So they're the ones that are going to be ushered into the exchanges more frequently. There is an opportunity for larger groups to be involved in the exchanges come 2016, I believe it is. But when they're first created, it's going to be 100 or less. Some states are going to have the option of making it 50 or less. So the definitions of what defines a small company are going to be a little bit different there.
Yeah, I mean, I think the law requires like preventive care to be covered, whether it's fully insured or self-funded at 100%. But the biggest advantage of being self-funded is the ability to be flexible around state mandates. And depending on what state you live in, some of those mandates can be pretty expensive and pretty onerous. So we're seeing a trend actually where a lot more employers are moving to self-funded that weren't in the past. And I expect that trend to continue. But
would you recommend that as a best practice?
I wouldn't recommend it as a best practice. I think it always depends on the size of the organization, the risk tolerance of the organization, and to be able to go into it eyes wide open about what those risks are. Certainly the smaller you are, the more variability in cost there is from one year to the next. And as long as you understand that that variability exists, and one good year or 2 good years doesn't mean every year is a good year, and you understand that, and you have the risk tolerance for that, then I think it's a decision that you should consider.
Okay, just to wrap this up, is there anything you'd like to add, or is there some things maybe we haven't covered that you think are worthy of mention before we close?
I was just surprised at the question of what do we do to keep our premiums down wasn't directly answered, but directly asked. That's,
I think people have given up on that.
Yeah, right.
And I apologize that we don't have a better answer on the waiver question.
The answer is there's nothing that can be done.
Okay. In respect to wellness programs, if you you want to know what I do to continue to make my body look this good, I'm going to get it. Okay, first of all, thank you. Chris, Mike, and Alex, thank you very, very much. We appreciate it. And thank you all.